Okay, sir. So, incidentally, today is also the World Osteoporosis Day, and we chose to take this lecture because it's World Osteoporosis Day, and nothing could have been better to include the osteoporosis talk in the same day. So, while we go through this talk, I believe we should be able to change our outlook as to how we sort of see the osteoporosis. We should be able to sort of be able to manage the osteoporotic patients, and we should be able to diagnose them and provide them adequate treatment. So, uh, just a moment before I'm just gonna unshare for a moment and then start again. Yeah. All right. So bone is basically a dynamic structure. It's not a static structure because it's sort of a bucket of water or a tank of water wherein water comes and water flows down. It's like a overhead tank. We all use that water and it needs to be replenished. So it's not a static structure. It's a dynamic structure, and it contains two type of things. One is the bone cells, and the second is the bone matrix. So cells form the matrix. The cells are primarily of three types, which are the osteoprotogenitor cells, osteoblasts, and osteoclasts. We all know osteoblasts help in bone formation, whereas osteoclasts help in bone resorption. So whenever there is a need for calcium in the blood, so osteoclasts will dissolve the bone and send that calcium into the blood. And whenever blood has adequate calcium and bones need it, so osteoblasts will sort of form the and help them deposit into the bone. So bone matrix now consists of three things. The bone mineral, which is sort of a thing which is there. It can be sort of inorganic. It is the inorganic bone material, which is two-thirds of the dry weight of the bone, and its collagen and its ground substance, which are also there. Bone cells are basically they form this complex structure. So in general, we should know about these 4 5 terms. One is the rank, and one is the rank ligand. So rank ligand is expressed onto the cells, and these cells can be then converted into osteoblasts. If there is adequate stimulation, they form osteoblasts. If there is a rank, then they form osteoclasts. And this is how they sort of work. So osteoblasts help in deposition, and osteoclasts help in resorption of the bone. So let's have a look at detail. Now this bone matrix contains of bone mineral, collagen, and ground substance. We just said this. Now let's try to understand what does bone mineral contain. The most abundant one is the crystalline hydroxyapatite. We all should know its formula because it can be an exam or a viva question. So it's Ca10PO4 whole 6, and it's a dihydrate, which means it's OH2. So this is the formula of crystalline hydroxyapatite, which is the most abundant mineral present in the bone. Then there is octacalcium phosphate. When we say octacalcium, you automatically know it's going to be 8. Since this 10 is replaced by 8, so you need something to replenish it. So hydrogen is there, and there is a bit of water content into it, and brushite, which is basically calcium hydroxyphosphate, and it's a dihydrate. So other one is collagen. Now collagen is, again, you need to understand that what type of collagen it is, predominantly type 1 collagen, and ground substance are also there, which are glucosamine glycans, chondroitin sulfate, osteocalcin, osteonectin, and the bone morphogenic protein. So bone morphogenic protein is believed to sort of stimulate the bone formation, and this has also been used clinically to augment the bone fusion. So we have bone formation, which is called as bone morphogenic protein. Now again, let's try to go back to the same diagram and understand if vitamin D is there and it is normal, the bone mineral will get deposited into the bone. But if the vitamin D is deficient, then all of these things do not change. I request everyone to keep their mics on mute, please.
Okay.
So if the vitamin D is adequate, then the bone mineral sort of is if the bone mineral is not there, it's osteomalacia. So if you have everything else which is there normally in the bone minus bone mineral, it is osteomalacia. But if everything is gone, that is osteoporosis. So this very important thing you should know, that only bone mineral gone, osteomalacia, everything gone, osteoporosis. So this is the basic difference between osteoporosis. Now, as I said initially, that the osteoporosis or the bone is not a sort of a single structure, is a stagnant structure. It's a dynamic sort of a tank wherein things come, calcium comes and calcium goes. So this is the cycle. So at around 25 to 30 years in male, there is a growth in bone mass by approximately 3% per year. And subsequently, there is a bone loss of 0.03%. And this sort of keeps the positive balance towards 2.7, plus 2.7. Now between 30 to 45, it's almost same. So as you are building the bone, you are getting the loss is also the same. So which means that this is the time when you get the peak bone mass. So there is something which is called as the peak bone mass. That is the maximum mass your body develops. And this usually happens between 30 to 33 years. And between 45 to 50 years, again, there is a slight increase in bone loss, but again, it settles down and there's a very minimal thing. Now, let's try to understand the same diagram in females. Now, at this point of time, initially 25 to 30, everything is same. They achieve a bone loss, but 30 to 35 till menopause, they have a slightly negative balance, which significantly becomes negative because then the bone formation is just 0.3 to 0.5%, whereas bone loss is 2 to 3% per year. And this continues once the menopausal hormonal thing subsides, it again falls back to the same value. But during this time of 5 to 10 years of perimenopause, lost a significant amount of their bone, and that is why osteoporosis is more common in females. And this is because the estrogen has a positive sort of a protective effect on bone, anabolic effect on bone. But once the osteoporosis is there, the estrogen effect goes away, and they tend to lose more. Comparatively, in males, the testosterone levels do not go down, and they sort of persist, and that is the reason why they develop less osteoporosis. So what is the consequence of the diagram which I showed you before? The consequence is by 80 years of life, women will lose 40% of their peak bone mass, which is a very significant value. Comparatively in males, they just lose around 20% of the bone mass. They don't lose a very significant bone mass. So the question is that are women only at risk, or does it happen in males also? Although the lifetime risk for fracture, developing a fracture in women is around 40 to 45%, it is much less for males, 15 to 27%. But understand very important thing that if you develop a fracture once, your second fracture risk is same. If a patient develops a fracture, whether it's a male or female, there is the subsequent risk for developing a fracture is same in men and women. What are the consequences of an osteoporotic vertebral fracture? Because the hip fractures usually need surgery, the risk can be managed conservatively. Rarely it leads to loss of quality of life, except for a bit of sort of immobility of the wrist, stiffness, and then some minor function loss, which in non-dominant hand nobody would care. But in a spine, they develop the silent fractures. They start developing this Doeger's hump, which we commonly call. So this back, which is round back kyphosis, this is because of the sequential collapse of vertebra in the spine, and this leads to Doeger's hump. So the people have to depend upon more analgesics and more painkiller medicine. There is a loss of height. The pulmonary function becomes restricted because the chest cavity gets restricted. The quality of life diminishes because you lose self-esteem. If you're not able to stand erect, you need a walker to move around. Obviously, you're not going to feel as great as you were when you were walking independently. There is a risk of paralysis also because the spinal cord runs through the spinal canal, and inadvertently they sort of trouble the nerves when they become unstable and increase mortality. Now, let's try to understand that what is this increased mortality risk. So with each standard deviation increase in BMD, there is a 1.3-fold rise in total mortality. So if a person has a BMD which is -2, a person with a BMD of -3 is 1.3 times more likely to have a sort of mortality. And for -4, it will be even more. Sort of, it will be even 1.3 into 1.3 times. That will be the level of increased mortality, which will be above 2.5. Now, if a patient develops a hip fracture, there is a mortality rate which has been quoted from 10 to 45%. Now, 45% is a very high number. Even if we consider 30%, it's very high, which means that 1 out of 3 patients who develop a hip fracture, which is osteoporotic and elderly and frail, they will not be able to survive beyond 1 year. And then there is again, subsequently, it increases to 1.8% every annual year thereafter, which is very, very high. So that's why the osteoporosis is called the silent disease, because 2/3 of the osteoporotic vertebral fractures are asymptomatic. 2 or more incident vertebral fractures, 1.4 times increased mortality risk. Older patient with hip fracture, mortality 20% higher. We just learned that 30% is the average. 50% of them need a long-term nursing care, and 70% of them do not return to the pre-fracture activity level, which means the activity level which they were doing, they could not return to the same activity level. That's why we need to label this as a silent killer and not as a silent disease. Now let's try to understand osteoporosis diagrammatically. This is a good woven bone, and this is osteoporotic bone where you see these voids because these were the places where the bone was there and it's not there. So it's a very weak bone. So if we ask the definition, it's a systemic skeletal disease characterized by low bone mass and micro-architectural deterioration, which means the strength which is there in the pillars of these trabeculae is lost, leading to enhanced bone fragility and a consequence increase in fracture risk. Now, everything we say about osteoporosis is in the last line. The increase in fracture risk is something which we try to control and we try to get rid of. And that is something what we need to do. There's something what we call as osteoporosis care gap. So it means that many people, including the doctors, are not aware about this silent killer or silent disease, and it results in lack of treatment. So a patient with hip fracture gets a fixation, gets a replacement, but does not get osteoporotic treatment. A patient with spine fracture gets better conservatively, but does not get osteoporotic treatment. Understand, they are going to develop these fractures again. So there was a very interesting survey done in 2005 where 3,422 orthopedic surgeons from 6 countries were studied. Orthopedic surgeons, I'm not saying eye specialists, I'm not saying anyone else. 90% do not routinely measure bone density following first fractures. 75% are lacking appropriate knowledge about osteoporosis. So this is what we call as a treatment gap. So if we look at patients who had subsequent hip fractures, so 45% of the incidental hip fractures describe the previous minimal trauma fracture. This means the people who developed this major hip fracture, which needed a surgery and all, they had developed a minor trauma fracture, which again, osteoporosis could not be detected in these cases. So these are common things which we miss. Somebody falling or sort of stumbling and then fracturing her wrist, and we do not think about osteoporosis, may again fracture her hip more. So osteoporosis is now a bone shattering thunderstorm, which we are trying to stop, and we need to get united in this fight against the osteoporosis. Now, coming back to the theoretical part, the osteoporosis is divided into two types, the primary and the secondary. As the name would suggest, primary, where there is no other pathology, it's just age related or something, and secondary, where there is a definitive pathology. Now, primary osteoporosis is type 1, which is post-menopausal osteoporosis. It happens in females when their period stops, quite simple to understand. And type 2 is senile osteoporosis, which happens in elderly people above 70, because then your bone sort of formation is very less and loss is going on. Subsequently, you've been in negative balance for a long time, and you have sort of worn out that bone. So type 1 osteoporosis primarily affects trabecular bone. That's why cancellous fractures are more common, which means the wrist and the spine. Type 2 osteoporosis affects compact bone. And if you see the canal of an elderly person, you see it is dilated because the difference between the inner cortex and the outer cortex is thinning. And that is what type 2 senile osteoporosis fractures. That's why hip fractures are more common in elderly people. And the younger people, when I say younger, I mean above 50 and 60, I'm talking about. And they suffer more trabecular bone fractures, which are the spine as well as the wrist fractures. Now, secondary osteoporosis can have various reasons. Endocrine, again, hyperparathyroidism, hyperthyroidism and hypothyroidism, both. Hypogonadism, as I said, testosterone, estrogen, they have effect on protective. If they are less, the bone mass is going to be less. Metabolic disorders of calcium, patient having renal problems, difficulty in absorption and all, they will lead to osteoporosis. Primary biliary cirrhosis, hepatitis, all lead to osteoporosis. Inflammatory bowel disease, celiac too, because of malabsorption and all leads to osteoporosis. Medicine, steroids are a known cause, and the term used for this is glucocorticoid-induced osteoporosis. So GIOP is the term what we use for osteoporosis because of steroids. And any marrow infiltrative disorder which replaces the normal bone marrow with a tumor tissue like leukemia, multiple myeloma, with question right how to quantify or assess the osteoporosis. So the bone mineral density by DEXA scan. So DEXA is written as DXA. It is not written as DEXA. So DEXA scan is the gold standard, and it gives your value in grams per centimeter square. So, and then you compare these values to a patient or to a person of young age, which is index age of 30, 33 years, peak bone mass age, and then understand how much your bones are weak as compared to that person. So this is what is there. So let's, for the benefit of students and exam purpose, let's try to understand what was the history of where did the bone density start from. So in 1963, low energy photon was first used to measure the bone density. In 1981, first bone density was measured, and this was used in calcified tissues. And then, and this is the used, and it was used, the rays used were from gadolinium source to a dual energy X-ray absorptiometry. The dual was used because it takes less time to take the reading. Single X-ray absorptiometry would take hours and hours to take. And then, and in 1987, the other company which sort of came as Hologic introduced Hologic introduced the bone density first in 1987 commercially. And these were the readings what were given by like that. So now this 25, 26, 25, 26, you used to sort of think about all these numbers and wonder what all is going on and where is osteoporosis and what should I be looking at. So that's why in 1994, WHO simplified to understand osteoporosis, and instead of these values, they came with something called as T-score. Now we call it T-score because it was named after Dr. Thomas Kelly, who described it. That's why we call it as the T-score. Now T-score, the formula is BMD minus a person of young value, a normal value, and divided by the standard deviation. This is the formula for the T-score. But in general, you remember that these are standard deviations below the normal, and that is much easier to remember than this formula. So WHO also classified and made the criteria for diagnosis of osteoporosis. Now, osteoporosis, normal bone density is considered from -1.0 to 1.0. Osteopenia is minus 1.0 to minus 2.5. Understand this is a negative value. So the higher the number, the lesser the value. Osteoporosis minus 2.5 and below, and severe established osteoporosis minus 2.5 and below, and osteoporotic fracture. So this is, they simplified that instead of reading those fine prints and values and thinking what to do about it, you just look at the T-score and see it. Now, who should undergo the bone density? Females more than 65 years or less than 65 years with risk factors. When I say risk factor, it means steroids, it means other diseases, what we talked about, secondary osteoporosis. Male, however, there's a National Osteoporotic Foundation who have the criteria that people have male above 70 or 50 to 69 years with risk factors should have this. With the illness or medication known to cause bone loss, steroids like anti-epileptics, they cause bone loss. And any patient being considered for pharmacological treatment, because you need to have a baseline to compare whether your treatment is helping the patient or not. And any patient who has not received pharmacological therapy, he is also a candidate for receiving. So in any patient who is not receiving therapy and in which the evidence of bone loss would sort of lead to a therapy, that you do. Now, we were talking about the National Osteoporotic Foundation criteria. So if the patient has osteoporosis, these are clinically oriented criteria, and osteoporosis and vertebral fractures on imaging, if you find, please get a DEXA done. Height loss of ½ inch or more within a year, height loss of 1.5 inches from the original height, then you should get a bone density done. And this hump is something what we call as a Doeger's hump. So if in the sort of in your OPD, you get a patient who has got a Doeger's hump, has been smoking or drinking alcohol in high quantity, sedentary lifestyle, low body mass index, which means lean and thin patients are more vulnerable to suffer from osteoporosis. Please think of osteoporosis and get a bone density done. The question people may ask you that bone density करा रहे हो तो radiation कितना लगेगा वो बताओ. So the radiation of bone density is much less. Let's see, this millisieverts is the formula where you sort of calculate the bone density. So the bone density test has 0.001. Let's think it with X-ray of lumbar spine 1.5, more than 1,500 times. CT spine 6 millisieverts, CT angiogram 16, and nuclear imaging like PET CT and all 40 millisieverts. So you can see here that bone density is much less radiation than doing even a simple X-ray. Once you do the bone density, how do you interpret the bone density? So on the top, there is a column wherein you have got the patient demographic details. You have the weight, you have the age, you have everything. Then you have a diagram where they show the reference markers. This UD is ultra distal, mid is mid, and 1/3 is the one which value we take significant as per WHO guidelines. So this will be given in bold. So this 1/3 is the one which you should be looking at. And you get a T-score, which is minus 4.2. So this is osteoporosis. And you also get this graph wherein you can find these are the reference lines as per age, and the red signifies osteoporosis, yellow is osteopenia, and green is normal bone density. So again, this is a normal bone density marker in green. This is severely osteoporotic, way beyond these reference lines. So this is the bone density which is there. And there is another one which is called as a Z-score. We talked about the T-score, means comparing of bone density as compared to a young person, and a Z-score. So if bone density of a 60-year-old, we want to compare it with the bone density of another 60-year-old who does not have any symptom or anything, then you have this something which you call as Z-score. So if your Z-score is less than -2, then you should think of secondary osteoporosis. It means that this is not within the normal range of expected value. It's much less. So you should have a Z-score less than -2, and it is better utilized in patients less than 50 years. Once you develop severe T-score like -4.5, -5, it's quite understood that the problem is there. You don't need to sort of split the hairs. And again, in this, these spine and hips are considered as the central measurements, and the forearm is considered as the peripheral measurement. There is also something called as a heel bone densitometry, which measures the bone density of the heel. We are not concerned about heel. We are concerned about preventing fractures in spine, hips, and wrists. So that are the three areas we measure in the bone density. Don't go by this. It's a screening tool. If the bone density is less, ask them to go for a bone DEXA scan, and it needs to be confirmed by a DEXA scan, and it cannot be used to monitor therapy. So let's try to understand that when these were talking about the bone density sort of levels, the T scores by the WHO. So we try to understand that after a critical analysis which was done, we try to understand, and more racial people, broad spectrum of racial people were added. And just by defining BMD saying minus 2.5 or minus 4 may not sort of alone comprehend the risk, because if a patient who has got minus 3 and has Parkinsonism has already fallen 5 times in last 2 months, he is or she is at a much higher risk of developing a fracture as compared to a patient who is minus 3.5 but does not have any other problem, is quite balanced, fit, and doing his regular activity. So that this is there is where the whole thing came. So we try to understand that this bone density is more than BMD. It's not the only value. So it depends upon the geometry, microarchitecture, and many other things. So that's why there is also something called as a qualitative CT or a QCT, which measures the bone density in three-dimensional area and sort of can help to find the stress strain index, which is also helpful in calculating the fracture risk. Now, because this is a CT, it measures bone density in volume. So the levels are given as milligram per centimeter square, which was given as grams per centimeter square in bone density. And you can directly measure the volume. If the trochanter you can measure directly the area of trochanter and calculate the bone density. And also understand that there are other independent risk factors which are there, like bone toxins and all, which we need to consider in this. So DEXA has a limitation that it cannot differentiate between osteomalacia and osteoporosis and other bone diseases. So this is what a clinician needs to do. That if the vitamin D is 7 and the bone density is minus 2.7, you should first replace the vitamin D, give enough calcium, and get it repeated in 3 months, and then decide whether the patient needs a treatment or not. Because this osteomalacia, you may unnecessarily give treatment when the problem is osteomalacia and you're thinking it's osteoporosis. So it's very essential. Now look at this thing. If you have an implant, the bone density will not be able to measure. If there are severe degenerative changes where the bone density software is not able to calculate the bone, and there are a lot of these white spots which are there because of sclerosis in the bone density calculates these as good density, and it is unable to differentiate between these densities. So this is the bone density of a patient in spine showing minus 1.7. Hip cannot be measured because the patient has already had a fracture and a replacement. And we may think that a bone density to acha. But when you look at the wrist and you look at the other hip, you realize the values are lying here. And this is what you need to rely, and not the one on the spine, because spine is masked by the degenerative changes. Of course, if you have implants in spine, that is another confounding factor. Then this plus 5.6 has got no value. You need to see this minus 3 and minus 3.5 and neglect these 12 and 12 values, because these are because of the screws in the spine. So WHO definition had a lot of limitations, and that is why it is essential that we consider each patient. And American College of Rheumatology, they suggest prophylactic bisphosphonate therapy whenever any patient they are starting any patient on more than 5 milligram per day of prednisolone for 3 months, and their T score is less than 1. So if patient is osteopenic and you are starting steroids, then they give a prophylactic bisphosphonate. And any patient who is above 65 years and they receive steroids longer than 3 months, they start on anti-resorptive. So to calculate the actual risk, there is something called as a FRAX. This was proposed by WHO, and it gives you a 10% probability of fracture. So it gives a probability of hip fracture and a probability of major osteoporotic fracture. And you need to consider these as a high risk groups. So if the patient has these FRAX score, you get a major osteoporotic fracture probability of 20% or higher, or you have a hip probability fracture of 3% or higher, you need to start on treatment. So this is a FRAX tool which is there, and you need to fill all of these data, and when you calculate, it sort of calculates the value for you. There's another score called as Q fracture. This is more to the native European countries. It's not dependent on bone density. In the frac, you can see you need to put the femoral neck bone density value. In Q fracture, it just asks you a few questions and calculates if you have a fracture risk, and that is what you need to understand. Again, for academic purpose, there is again a Garvan score, but it's mainly for Australian population, and there are comparative features, but this will be too much going into detail, and we will straight away go to the investigation. So whenever you get a patient of investigation, you should do a CBC, you should do a ESR, because in multiple myeloma, in leukemia, in marrow infiltrative disorder, this ESR will be very high. Serum calcium should be done ionic, and if you're not having ionic, then you should calculate the values with albumin. I'll show you that in some time. Look for phosphorus. Sorry, this is a typing error. It's not PO4, it's phosphorus. It's serum alkaline phosphatase, parathyroid hormone, and vitamin D. Metabolic workup, also look for SGOT-PT, creatinine for kidney diseases, thyroid profile, and a spine X-ray to sort of understand if there are already fractures happening. So whenever you write for calcium test, also do albumin along with it, because if you're doing a non-ionic calcium, understand calcium is in two forms. One, it is bound to albumin, and second, it is free in the blood. If albumin level is more, your calcium will also be more. If albumin level is less, your calcium level will also be less. But that does not determine the free calcium level in the blood, which is what matters. So if you do a calcium, you do a bit albumin test along with that. And there's a formula that if you consider 4 as normal, so you add calcium plus 0.8 into 4 minus albumin level, that gives you the corrected calcium. For example, let's say a patient has a calcium value of 9.8 and you think that it's normal value, but the albumin is 3 grams. So now when you apply this formula, the corrected calcium comes to 10.6, which means the patient is having hypercalcemia. And before you sort of write for the calcium test, specifically write that do not apply tourniquet and do not tap the vein, because both of these alter the calcium value and your calcium levels may be unnecessarily high. So osteoporotic x-rays, unless you have a 40% decrease in the bone mineral, you will not be able to identify the bone x-rays. This is a normal or a reasonably age-adjusted normal x-ray, and this is osteoporotic x-ray. You can see these multiple collapses which are there, which point to previous underlying fractures, that's why it's called as a silent disease. So if you sort of go beyond these and there are doubts, then there are advanced investigations which are there for the osteoporosis. Now there are bone formation markers. P1NP is commonly which we monitor whenever we start teriparatide, because it gives you a result in 2 months whether your teriparatide is working or not. And there are bone resorptive markers which are checked either in urine. If you're checking in urine, then it's a 24-hour collected urine, and serum CTX or serum beta cross lab. These are the common sort of tests which we do as a bone resorption markers. So whenever we talk about the management and you're in doubt, understand I told you it's like a water tank, water comes in and water goes out. So if you're talking about perimenopausal osteoporosis, when the bone formation is good and the bone loss has suddenly increased, if you stop this bone loss, you will be able to. So this is what bisphosphonates and all do. They sort of prevent this bone loss, and your normal bone formation tendency will increase the bone mineral density. Now consider the elderly situation, an 80-year-old person, the water going out of the tap is very less, the water filling in the tap is very less. If you're going to plug this, it's not going to fill up so easily. So that's why you need an anabolic sort of condition, and it will fill up the bone, it will fill up the tank easily. And once you have filled up the tank, then you plug this hole by following up that teriparatide with a protective therapy like a denosumab or a bisphosphonate. So understand this more simply like that. If you've got money in your locker and you want to stop it, then you put a lock into it. But if something like demonetization has happened and that money is of no value or it is lost, then you need more money to sort of put into, you need new money to put into that one. So that is why you need anabolic pump over there. So the intervention level of the patient has to be when the patient is of this early sort of young person, not when already the hump has happened and the patient's quality of life has diminished. So this is the time when you should look at intervening and educating people about osteoporosis in your clinic, especially the females who are in young age group. So preventive strategies are based on these few things, which are genetic factors, endocrine status, nutritional factors, and physical activity. Now, the first one, genetic, you can't modify, you can only quantify the risk. Endocrine status, if the patient has thyroid or other problems, or you should be corrected so that the bone density is not affected. Nutritional factors and all should be corrected. There are customary traditions and people who are fasting and who are purely vegetarians, they are more prone to develop osteoporosis as compared to other ones. And physical activity has to be weight bearing activity. It should be something like walking, like jogging, or good aerobic exercises. And it should be done daily or at least 5 to 6 days a week to keep your bone in good health. And people who are elderly develop high risk factors, something which we call as sarcopenia, which means as the people grow older, they become thinner because they lose muscle mass, and that muscle mass loses the cushioning effect they have on the bones. So if the trochanteric fat pad is less, then the patient is more likely to develop a hip fracture. If the trochanteric fat pad is good, then we can sort of prevent that fracture. So medication, if the patient is on sedatives or Parkinsonism, where the patient has a tendency for falling, so they come as high risk category. Ensure that environmental safety is there. So all of these patients who are high risk, you should educate and advise them about padding their floors so that even if they fall on soft floors. Railings should be installed in toilets to get up from the commode and get up from the chair. Many of these patients fracture spines when they are getting up from the sitting position. And previous falls, especially sideways falls, need to be taken very seriously. So as we were discussing before, the pharmacological treatment is of two types. One is anti-resorptive and one is anabolic, the one which plugs the loss and the one which fills up the tank. So anti-resorptive mainly are calcium and vitamin D and other hormonal replacement therapy, selective estrogen receptor modulators, calcitonin, bisphosphonate, denosumab, and the new drugs which are now coming into the market. So anti-resorptives are calcium and vitamin D. They are not totally anti-resorptives, but at least if they are normal, they will prevent severe bone loss. Calcium, daily requirement for calcium is around 1000 to 1300 milligram per day, depending upon age, requirement, and all. And if you are giving a patient a calcium tablet and you are giving more than 500 milligrams, like take 2 tablets together, it's not going to get absorbed because this is the intestinal cut hole. It will not get absorbed over there. And the ideal time to take calcium tablet, especially carbonate formulation, are tablets which are the older this thing. The best time is to take them is after dinner, around 2 hours after dinner, and after that, so that you are empty stomach, you don't have any food which interferes with the calcium absorption. A newer salt called calcium citrate maleate is independent of the food absorption because it depends upon amino acid transfer, and you can get better absorption in these ones. Vitamin D, the daily requirements are 2,200 to 400 international units. In children, it is more, 400 to 1000, and in elderly population it is 1000 to 2000 international units per day. But we know from our experience, especially in Indian experience, that you need minimum 1000 international units of vitamin D to be given daily in order to prevent from happening. Sunlight is a factor we know which helps in vitamin D, but the sunlight needs to be taken between 11 a.m. to 12 p.m. That's the time when your body can form vitamin D. Early morning sunlight cannot form vitamin D. And as a general rule, if the shadow is longer than your body, you cannot form vitamin D. And you need 10 to 15 minutes of exposure, and 40% of the body has to be exposed. That is how you will get the vitamin D normally. Injections for vitamin D are not better. They lead to more toxicity. Oral supplementation is preferable unless you have absorption problem. And understand this thing that oral supplementation, this is peroral supplementation. Peroral supplementation attains peak more quickly as compared to injections, which take longer time. And weekly doses are better. They sort of give more sustained formulation, and then you take care of the maintenance therapy. Do not prescribe 3 to 6 injections of vitamin D. They will lead to toxicity. If at all you're forced to give injection, give one injection and recheck vitamin D in 3 months. And do not combine injection and oral. They will lead to toxicity. Another word of caution is for calcitriol or alpha calcidol. This is activated vitamin D. It is meant to be given in renal osteodystrophy to suppress PTH and to treat hypocalcemia because of severe hypovitaminosis D. So these conditions you give calcitriol. It's an activated vitamin D. It will just pull the calcium into the blood, cause hypercalcemia, and many of these patients later may have heart calcifications, vessel calcifications, or kidney stones. And recheck the vitamin D once you have corrected it. Anti-resorptive like hormonal replacement therapy have very narrow indications. They have cardiovascular side effects and also rapid catch-up bone loss. That's why they are not very popular. And the same problem with the selective estrogen receptor modulators. And there are also increased risks for endometrial and breast CA. Now coming to very important thing, calcitonin. Calcitonin as an anti-osteoporotic is not recommended. Both European agency and the FDA has banned use of calcitonin for osteoporosis. It is meant to be used in very few circumstances. One is to use in Paget's disease to prevent acute bone loss, and it is given to suppress to sort of decrease the calcium if there is a hypercalcemia. If you have a patient of multiple myeloma, calcium is running very high, you give calcitonin to suppress it. It also is believed that calcitonin sort of has a opioid receptor mechanism and it helps to reduce pain in osteoporotic fractures. But again, prolonged use of calcitonin like 2 months, 3 months will lead to antibodies because this is mostly salmon calcitonin. It leads to antibody formation, and beyond that, it does not have any benefit. So, and in general, more than 3 months is not ever recommended. And coming to the bisphosphonates, there are mainly 4 types of bisphosphonates which we use: alendronate, risidronate, ibandronate, and zoledronic acid. I'm not touching pamidronate because it's a different drug and mostly it's not included in osteoporotic treatments routinely. So current recommendation is that after a 5-year period of these drugs, you need to give a break and you need to sort of give a treatment holiday, because 2 complications are there. One is osteonecrosis of jaw, which means that the jaw may have an unhealing ulcer or anything over there. So you can, after 3 years, you can get a yearly dental examination done or ask patient to report if anything is like that. And atypical subtrochanteric fractures, they are also known to be caused with these anti-resorptive. So after 5 years, it's recommended to give a drug holiday. The denosumab is again a newer drug. It's a rank ligand inhibitor. Unlike bisphosphonates, you can give denosumab for 10 years also. And this is given as a follow-up therapy also after teriparatide. We all know denosumab is also used in treatment of GCT to shrink the tumor before we sort of go for the curative surgery. And this denosumab is basically a rank it works by this rank ligand. It's a fully human monoclonal antibody against rank ligand, and that is how it prevents the osteoclast from getting activated and causing a bone loss. Other antiretrovirals also given as phase trials. Now, anabolic agents are other steroid growth hormones, anabolic steroids and all, but the one which we are most common is the teriparatide one. There are other newer drugs which are beyond they are not yet into the market. Now, teriparatide is meant to be used in patients who, as a one-time therapy for up to 24 months. And before doing this, your PTH should be normal. There should not be any malignancy which is there. There should not be hypercalcemia. It's given as a 20 microgram subcutaneous self-administered dose. There are a bit of concerns of osteosarcoma in animal models, but that was studied in rats. till now, we don't have enough evidence to prove that they may lead to sort of osteosarcomas. Anyways, the rats, the animal models which were used, they were growing, and we don't use teriparatide in growing children. We use them in elderly. So there was a bit of a factor in that study that they were growing rats, and we use them in normal individuals. Strontium had come a long time ago, but again, it's a very good drug, very effective. But again, sort of there were risks for myocardial infarction and other things. That's why it went out of the market. So the take-home message from today's talk is that prevention is better than cure. You have to identify the target population early. There are people at risk. You need to identify and treat them, and it needs to be customized treatment and doesn't. Thank you very much.